The managed trial was a randomized controlled trial of 1,754 patients who had developed myocardial injury after non-cardiac surgery, which was either a myocardial infarction or an isolated ischemic troponin elevation. They were randomized to dabigatran 110 milligrams twice daily or placebo, and they took the drug for a mean of 16 months after randomization. In the main results that we presented at the AHA, we demonstrated that dabigatran reduced the risk of major vascular complications, about a 28% reduction, statistically significant, and had no increase in major bleeding. Those are the primary results that have already been presented. The rationale for doing additional analyses was that 46% of the patients in the dabigatran group and 43% of patients in the placebo group had permanently discontinued the study drug during follow-up. This had mainly happened because it was mainly because of patient request, and that was because a lot of publicity came out about dabigatran and a question about myocardial infarction. So we wanted to undertake per protocol analyses where we would count events up until 7 days after patients permanently discontinued the drug to have an understanding of, amongst patients who are compliant with dabigatran, what might be the true treatment effect. We also undertook analyses where we evaluated events after patients permanently discontinued the drug to see whether or not in fact there was any increased risk after people had stopped the drug. And that's why we undertook these analyses. So the results in terms of what we presented here today was showing that similar to the original publication, major vascular complications are decreased in the per protocol analyses amongst the patients who were compliant. However, it's a bigger treatment effect. So it suggests that there's about a 45% reduction in major vascular complications amongst patients who are compliant with drugs. Moreover, what we saw was in fact that there was a mortality reduction. There was a reduction in myocardial infarction, and there was also a reduction in venous thromboembolism. So that's what the per protocol analyses showed. We didn't see any excess in terms of life-threatening major or critical organ bleeding. However, we did see an increase in major lower GI bleeding, and we also saw an increase in ISTH major bleeding in the per protocol analyses. For the analyses looking at events after patients stopped taking the medication, what we saw was that there was an excess in cardiac revascularization after patients stopped taking the medication. However, the two curves don't start to diverge until about 2 months after patients stop taking the medication, and we didn't see it for any other outcomes, suggesting that, in fact, likely the post discontinuation analyses may be a chance finding. However, the per protocol analyses suggest, if anything, that if patients are compliant, we can expect even bigger treatment effects. So I think the conclusions from these additional data is that amongst patients who are going to be compliant with the medication, there's reasons to actually believe that in fact you're not simply going to get a reduction in major vascular complications, you likely are going to decrease the risk of mortality, decrease the risk of myocardial infarction, and also venous thromboembolism. However, it is important to note that the arterial events were tenfold more common than the venous events. So the real dominant effect ends up being on the arterial side. You will, however, get some increased risk of ISTH major bleeding, but importantly, the overall balance is that you'll prevent twice as many major vascular complications compared to the number of bleeding events you'll cause. So I think that this offers even more encouraging evidence for us to be using dabigatran in patients after non-cardiac surgery who develop myocardial injury.